It's 1:04, so I think we can start. Welcome everyone, and thank you so much for joining this EANO Youngsters webinar. My name is Marjolein Geurts, and I'm co-presenting this webinar with Barbara Kiesel. We are both members of the EANO Youngsters Committee, and this is the third webinar we are organizing with our committee. I'll start with some general information before we can really start. With this webinar, we aim to address residents, young members of staff, PhD students with a very educational perspective. We did a Facebook poll to find out which subject was necessary to address in this webinar, and it was very clear that most people that are in our Facebook group wanted to have the primary CNS lymphoma to be discussed. So that's what we did. We are going to do a very normal tumor board, just as you do in your own center. So this is a tumor board, and I'm going to present a case, and in our team we're going to discuss what the best way to treat this patient is. We aim for a very lively discussion. So if you have any questions, if there's anything you want to know, please ask questions via the control panel. Because there's two things different today, different from what you normally do in your own tumor boards. The one thing is that you can ask anything you want to know, so there's no stupid questions. Please don't hesitate. Barbara will handle the questions, so you can interrupt and ask our experts anything you want to know. This is important because that's the second different thing from your normal tumor boards. Namely, we have an expert panel. We found real experts from all over Europe prepared to discuss this case with us. So let's just start. Before we start with the case, become a member of the European Neuro-Oncology Network. If you're not a member, please know that EANO is there for you, not only if you are a medical professional for years, but also for the next generation. So this is important, and please consider that. I think that the housekeeping is important to mention here. Again, we are aiming for a lively discussion, so if you have questions, don't hesitate to ask them via the control panel. Before I start the case, we want to introduce you to the expert panel. Barbara, could you introduce our experts?
Yeah. So we have Adelheid Wöhrer from Vienna, Austria, as our neuropathologist. The neuro-oncology is represented by Schlegel from Bochum, Germany. Then we have Georg Widhalm as our neurosurgeon from Vienna, Austria. And Teresa Nunes from Lisbon, Portugal, as our neuroradiologist. And the radiotherapy is represented by Richard Cowan from Manchester, United Kingdom.
All right, so let's just start with the case. This is Mr. A. Mr. A is 58 years old, and he was formerly healthy and very fit. But since about 2 or 3 weeks, maybe a bit longer, his wife mentioned that he was slow. He fell asleep during conversations, and that's not the one he usually is. So they went to the doctor, and the neurologist found a bradyphrenia. The patient was really slow, but there were no focal deficits or other abnormalities, and he had a performance status of 1. So the neurologist asked for an MRI, and the MRI we see here. And before we go to our neuroradiologist to tell us what we actually see, we want to ask you a question, a poll, about what you think that the diagnosis is. And I'll go back to the slide so that you can have another look, and Barbara will do the voting.
We have 70% already answered. I will close the question in 5 seconds.
I'm afraid we lost Barbara here. Connection. Oh, yeah.
So
we are.
here we have our question. What is the diagnosis of lymphoma?
I don't hear Barbara anymore, do you? No. Oh, well, I can see the results of this poll. Most people think it is lymphoma, but they say there is a differential diagnosis. Well, Teresa, what do you see on this?
Hello, thank you very much for the opportunity to be here. So in this MRI on the top row, we see T1 weighted images pre and post gadolinium, and we see that there is a single intraaxial lesion in the splenium of the corpus callosum in the midline. It shows solid, a little bit irregular enhancement. And on the images on the bottom, you see an ADC map where you see that there is no restricted diffusion in the lesion, and also a susceptibility image where you don't see any foci of hemorrhage. Then you have a spectroscopy, part of advanced imaging techniques, where you see an increased choline peak. You hardly see the NAA peak, and you see a little peak of lipids. So regarding the differential diagnosis in a lesion like this, we would start by thinking about intraaxial lesions that affect mainly the corpus callosum, and two main differentials come to our mind. One is, of course, lymphoma, and here we would have a pattern of enhancement that is quite typical. We don't see the restricted diffusion that sometimes is a hint for the diagnosis. And the spectroscopy is also quite typical in this case, with the very high choline peak. Sometimes we have even bigger lipid peaks. The other differential, or the main differential diagnosis in this case, would be GBM. But in that case, we would expect the enhancement to be a little bit more heterogeneous, very often with necrotic areas and some hemorrhage in the susceptibility images. This is not a very common location for metastasis, and the pattern is not also, the pattern of enhancement is not common for instance, a toxoplasmosis, where we would generally see ring enhancement, sometimes with a target sign. So I think that this is quite typical of lymphoma, but yes, I think we should also think a little bit about the differential diagnosis here.
Thank you. So we have a very clear corpus callosum involvement. You were saying lymphoma, that is typical. What else do you think if you see the corpus callosum involvement rather than lymphoma?
So generally, we would have to think about the GBM, so glioblastoma, and sometimes, but the pattern is quite different. Some demyelinating diseases may also affect the corpus callosum, but the pattern of enhancement would generally be quite different, and generally you would have other lesions in the periventricular white matter too. And this lesion, also another thing that is important is that you don't see very much edema, and there is only slight mass effect on the atrium of the left lateral ventricle, but there is not a huge mass effect in this case.
So you're actually saying this is typical lymphoma?
This is very, the characteristics are quite suggestive of lymphoma. But I think that in this type of lesions, I think you should always keep your ideas wide regarding the differential diagnosis. But I think this is rather suggestive of lymphoma, I would say.
Thank you very much. So actually most people answered the poll just the way you answer it. This is probably lymphoma, but we have to consider a differential diagnosis. Okay, let's continue to the second poll. Would you give steroids now? Barbara, could you do this poll?
Yes. So would you give steroids now? Yes or no? So we have 72% already voted. We'll wait for 3 more seconds. Okay. So, so the results show that 95% would not give any steroids.
This was one of the learning objectives, at least something that we really wanted to address, the steroids and lymphoma. There's something going on. Everybody knows apparently that you don't give steroids. We will come back to this later on to assess why you actually don't give steroids. But let's continue for now. We have this MRI. A 50-year-old patient, formerly healthy, suspected CNS lymphoma. The third poll to get you all on board. Who do you call?
Who do you call? The neurosurgeon, the neuro-oncologist, the hematologist, the medical oncologist, or the radiotherapist? So we have 67% will call the neurosurgeon, 20% the neuro-oncologist. The hematologist will be called for 8%, 6% will call the medical oncologist, and nobody will call the radiotherapist.
Well, that's interesting. Well, we have a neurosurgeon on board, well, let's ask the question. Georg, how do we proceed now?
Yeah, that was a good decision that you call a neurosurgeon. In this case, if it's a suspected lymphoma, of course, it's very important to have a histopathological diagnosis to be able to base your treatment on the histopathology. So normally the patient will come with an MRI to a neurosurgical department. We already have heard that we have very good advanced imaging modalities, so it's always important to have a fusion MRI and to have all this differential diagnosis. So if you have the patient comes to your department and you have suspicion of a CNS lymphoma, normally you have 3 different possibilities. First, if it's suspicion of a lymphoma, and in this case, like in this case, it's deep-seated, you would normally do a biopsy. If it's deep-seated, normally you would do a needle biopsy. If you have a more superficial lesion, you also could plan an open biopsy. And so the second possibility is if you have a CNS lymphoma and it's not 100% clear from the differential diagnosis. There are some cases where you say, yeah, maybe it's a lymphoma, but it could also be a GBM, for example. Then you can plan open biopsy, make an intraoperative histopathology, and then you decide if it's a confirmed lymphoma during surgery, you can stop the procedure. And if you have a GBM, you can perform a tumor resection. And the third possibility is if you have really a space-occupying tumor and the patient has a lot of neurological deficits and has some headaches or vomiting, then you also have to consider a resection of the tumor, of the tumor mass. That's very rare, but there are also in the clinical routine. I also had some cases where you really had to do such an emergent resection. But normally, if you have such a lesion that we could see here, a deep-seated lesion in the splenium of the corpus callosum, I would recommend to do a stereotactic needle biopsy. Normally, to prepare this needle biopsy, you do a MRI scan with contrast media on the day before you do the surgery. Then you integrate these images into the neural navigation, and then you do a navigation guided biopsy with the target of the contrast enhancing area in the splenium. And then normally we do a intraoperative histopathology. That's in some hospitals you do it like that, and in others you don't do it. So that's really different from hospital to hospital. And in Vienna, it's our practice that you normally do intraoperative histopathology.
We have a question for the audience.
Yeah.
Are there cases where the biopsy can be omitted? For instance, if the CSF is indicative for of lymphoma.
That was a Schlegel.
May I interfere, Marjolein? And we would like to have a vivid discussion, and I would like to interfere because we are set now on the neurosurgical point of view. And I would get back to the question, is there a possibility in rare instances to avoid histopathological diagnosis by a neurosurgical procedure at all? And I'm a neurologist and conservative, and I would like to step back and ask some questions to this patient. For example, if he had some visual disturbances in the near past, like, for example, symptoms suggestive of an ocular lymphoma. And the next question is, of course, is it of any risk to make a CSF sample by this patient? And as far as the clinics and the MRI shows, the CSF lumbar puncture is without any risk in this patient. And the question is correct. Maybe there are some places and cases when we can actually fix the diagnosis by CSF, or if the ophthalmologist sees an ocular involvement by vitrectomy. Yeah, so we have to consider the differential diagnosis, and what we come at in, I think, 80 to 90% of the cases, that in fact the neurosurgeon has to take a biopsy and fix the diagnosis with the help of the neuropathologist. But there are definitely cases where we can make the diagnosis on CSF or vitrectomy.
So you're saying 80 to 90% we need a neurosurgeon, but there are cases where we can avoid the neurosurgeon. How many lumbar punctures do we need to do?
How many lumbar punctures do we have to do? So in my center,
please go ahead.
It was just to add to that very valuable point, particularly with ocular lymphoma, which I think historically has been a little bit underdiagnosed in the past, and we haven't always routinely sent patients for ocular examination in these sort of circumstances. The only difficulty there is the amount of, as we know, the amount of tissue that is obtained is quite small, and sometimes the histopathologist, and maybe our histopathologist try to comment on that, it can be difficult to make a diagnosis distinguishing between a rather florid uveitis and a lymphoma in the eye.
Yeah, so that's a very good question, I have to say, because there are some conditions really when the patient is in a bad condition or has a very deep-seated lesion that you really cannot do a biopsy. In my experience, but I had never a case where you really had to base the treatment on the results of this lumbar puncture. So in the end, it was always necessary to do a in the end a biopsy. So I didn't. Or Heidi, what do you say? Is it possible really to make the final diagnosis, also the subtypes, only with CSF from a lumbar puncture?
That's a good question. So for the moment, I do not believe that a full assessment can be based on the CSF puncture, but there is the hope that we will proceed with the liquid biopsies, and we can also do a gene panel sequencing, for instance, on cell-free tumor DNA from the CSF. So this will be an option in the future. It is increasingly recognized in the research setting. It is not yet translated into the routine diagnostic procedures, at least not in our center. And when simply considering the CSF cytology, so really looking for the lymphoma cells, and I fully agree. I think I remember a single case where we had convincing lymphoma cells in the CSF. But then we are very limited in the assessments we can do based on the cytology, so we can stain for selected immune markers, but we cannot do like a full panel of stainings. So in this situation, because usually what we have is a situation where the fraction of the lymphoma cells in the CSF is relatively low, so there are only single tumor cells. It's not that we have like 20 or 30% lymphoma cells, the CSF.
So let's take one step back. Why would we want to avoid the neurosurgeon to get a diagnosis? I assume there are some complications of a biopsy or maybe even resection. Georg, what are the chances of what complications do we need to take into account?
That it depends really on the localization of the tumor, but the most common complications are it could be a hemorrhage after the biopsy, it could be infection. Especially in my experience, infections are relatively high incidence in lymphomas, in lymphoma biopsies, because normally they get high dose corticosteroids after the biopsy. And then it's really, I think, a predisposition that the patient has some problems with the wound healing or infection. So that, I think that's not so uncommon. And of course, the complication is also if you have a non-diagnostic tumor biopsy. If we cannot do the final diagnosis. That I always have to tell the patient that's associated risk of a biopsy. You have some technical problems or the small lesion is very small, that you have cannot do a final diagnosis. It's fortunately very rare, but that's a possible complication, of course. And the other problem,
I'm sorry, I want to be very clear. We don't want to avoid the neurosurgical biopsy. It's just for the rare cases where we can do a solid diagnosis on other grounds. These are very rare cases, but before we ask the neurosurgeon to take a biopsy, we should make a history of the patient, and we should ask for some additional clinical symptoms that may lead us to the diagnosis. And I completely agree with Dr. Wöhrer that these are exceptional cases where you can put the diagnosis on CSF cytology. That's absolutely true, but it's a chance, and we should not leave out this chance to make the diagnosis just in CSF.
That is a clear point. Thank you very much.
I don't know if I can just make a slight comment, is that sometimes this information from the clinical history and other exams also helps us when the MRI is not so typical of one diagnosis over the other. Sometimes we can put information together and just be more confident on the result of the MRI. Thank you.
Which also is true for the neuropathologist. I mean, it helps a lot if the neuropathologist has all clinical information, relevant clinical information.
All right, so I think we've heard the pros and cons of CSF, and according to all questions we have, I think it's more or less clinical practice in most centers to do at least one lumbar puncture before a biopsy is taken, but that's just generally spoken. How fast do we need to be, Georg? How much time do we have?
Yeah, normally you should do it relatively fast, the procedure. So we try, if we have the patient in our hospital, normally we do the MRI scan for navigation, and then we try to do it on the next day, or yeah, I would say 1 or 2 days normally we wait. Because the problem is that also the patients have some symptoms often, and after the biopsy, it is confirmed during the intraoperative histopathology, you can administer corticosteroids, and then normally the patients really recover very soon, and also with clinical symptoms. So that's really important to do it relatively fast, that you can administer corticosteroids.
Okay, so if I proceed with the case, in this case we indeed did CSF first, which did not give us any confirmation of the diagnosis. Neither did the ophthalmologist, and we also performed a PET CT to see whether there were extracranial abnormalities. Answer: no, and this costed a few days, and in the meantime the patient deteriorated, so we had to start steroids, and we didn't have a diagnosis. So this patient is on steroids for a week now, and now I wonder, Georg, what do you do with this kind of cases? We have a patient on steroids. Do you do a biopsy, or do you first stop the steroids? What are your thoughts about this?
Yeah, I think that's a really very important question, of course, with the corticosteroids, because if a patient gets to the hospital with this MRI and the suspicion, despite the suspicion of lymphoma, in my experience, approximately 50 or 60% of patients already received corticosteroids. So of course, if the patient comes to the hospital, to a new surgical clinic, we immediately stop the corticosteroid treatment. And if it's possible to wait some days, then from the clinical symptoms, for example, if the patient has only mild symptoms in the small lesion, then I think it's okay to wait some days and postpone, for example, for a week the surgery and make the biopsy afterwards. If you have a patient that has a large lesion with a lot of symptoms, I would not wait, and then I would do the biopsy very fast. So it depends a little bit, in my opinion, from the clinical situation and also from the size of the lymphoma. But yeah, that's my opinion. I think there are always discussions how you do it, and then there are no clear guidelines. But that is the strategy that we are doing here in Vienna.
So what are the chances of a diagnostic biopsy if the patient has had steroids? Is that like 0, or what is your experience?
No, we had some cases that we had to biopsy, of course, with the corticosteroids, and in the majority of cases, despite corticosteroid treatment, we also had a definitive diagnosis of a lymphoma. But there are some cases, I think Heidi will know it much more better, where it could happen that you can do a final diagnosis. Mm-hmm. Heidi, how high do you see the chance of, or is it a frequent event?
I think
by diagnosis because of the corticosteroid?
I guess as long as there is contrast enhancement and you target the contrast enhancement site, then there should be, so the histology should be diagnostic. At least this is our experience. There are some cases where we have the differential diagnosis of some inflammatory process, also very prominently including some demyelinating disorders such as multiple sclerosis. So it can be difficult and sometimes tricky to differentiate. But the majority, let's say more than 70 or 80% of the cases should be fine.
Yeah, that's also completely agree. Some single cases that we had to do a rebiopsy. First, we only had some infiltration or suspicion of a lymphoma, but we couldn't do a final diagnosis. And then we did it some weeks afterwards and then could confirm it. But that were only single cases.
Just to confirm, what a challenge this is. If a patient deteriorates quite rapidly, so the steroids have to be given for a few weeks, we tend to do another MR scan to assess exactly as we're saying, is the residual disease suitable for biopsy? And I'm sure we've all had experience of patients where the MR scan shows so little that we have to wait. And there can be quite a delay before it grows back sufficient for the surgeon to do it. And I think that shows the very close collaboration between the surgeon and the radiologist and the team looking after the patient to get that timing just right.
I fully agree. We should actually differentiate between two situations. We put patients on steroids and they are worsening and the contrast enhancing mass lesion is increasing. Then there is a need for immediate biopsy and we have a high chance. The other situation is the patient is improving and the contrast lesion is decreasing. And I would disagree in this point with Dr. Wöhrer. Even if you have contrast enhancement there in a decreasing lesion, the chances are high that you show the inflammation and the T cells, but the B cells are gone. So it's rather simple if patients are improving and the contrast enhancing lesion is decreasing in size, you have to wait and monitor by repeated MRI until it's increasing again. But in the other cases, when the contrast enhancing lesion is increasing and the patient is worsening, then it's a clear-cut indication for immediate biopsy with a high chance of getting a diagnosis, despite steroids.
Thank you. All right, so I think we already talked about the biopsy versus resection, so I wanted to continue to the 5-ALA. What is this, Georg? Can you help me?
Yeah, 5-ALA is a fluorescent dye that leads to intratumoral accumulation of fluorescing porphyrin 9. And then that fluorescence dye is usually used in high-grade gliomas for intraoperative fluorescence-guided resection. And some years ago, we also started to use 5-ALA in stereotactic needle biopsies. And similar to the open resection, we also checked the specimen that's in the needle for some fluorescence. And we could confirm in a study together with Heidi that normally, if you see this fluorescence, it is also diagnostic. So we changed a little bit our strategy that if we have cases of a stereotactic needle biopsy, when we have really strong fluorescence of this tissue sample, we terminate the procedure and do not wait for the intraoperative histopathology. So, and that's normally we wait. Of course, the new pathologists are very fast, but it takes a little bit of time for the transportation and so on. So, of course, then we would save some time, and also it's of course for older patients if you have not so much time in anesthesia. So I think it's a good strategy that if you have this strong fluorescence, you can be sure that you have a have a diagnosis. The problem is you cannot say what tumor it is. It can be then lymphoma, or it could also be a GBM. So it also only confirms you, or tells you the probability is high that it's a diagnostic tumor tissue inside. So that's, of course, then the advantage of the intraoperative histopathology, that you also can say which tumor it is normally. In these cases, yeah, we often do this stereotactic biopsy with 5LA and have a good experience. Often or normally, if you have the fluorescence, it's also diagnostic. So it saves time.
We have some questions of you in action. I think this is you doing a biopsy, is that right?
Exactly, that's a navigation guided stereotactic biopsy. So it's already approach to the contrast enhancing lesion. And then I have this operative microscope, sterile, and then under this microscope, I check this needle with the tissue sample inside and check for potential fluorescence. Yeah, and that's illustrative case of this tissue sample inside the needle. And on the right image, you see this bright fluorescence. So if you see this during surgery, you can be very sure that it's a diagnostic tumor tissue.
Okay, well, I think that makes things really clear. So we go back to our case. We have tissue now. Tissue is the issue. Heidi, can you tell us what we see here?
Yeah. So in this case, we're lucky as the histology is quite diagnostic. So we see this dense proliferation of these large lymphoid cells. They tend to cluster around the vessels, but they also diffusely infiltrate the brain parenchyma. And when we go on to the next slide, we have a higher magnification of the nuclei. And you see these large nuclei with this multiple nucleoli. This is very suggestive of some centroplasm morphology, and we see many mitotic figures. So this is really an active and high-grade malignant lesion, which is also supported by the MIP1 proliferation index, the next one, where you see it's almost 100%. So actually, every cell in this tumor is actively cycling. So we know it's a malignant lesion. And if we are looking at the more extended marker profile, the next slide, please, then we see there is a strong expression of B cell markers. So all the tumor cells are positive for CD20 and CD79A. There is also some infiltration of lymphoma infiltrating T cells and also some infiltrating macrophages. So by now we know it's a malignant B cell lymphoma. And actually the vast majority of primary CNS lymphoma fall in one diagnostic category, which is the diffuse large B cell lymphomas. Next. So the classification of these lymphomas is strongly based on the cell of origin, and we differ between two transcriptional subtypes. First one is similar to germinal center B cells, and the second one has a gene expression profile that is reminiscent of post-germinal center B cells or activated B cells. This information is important for you as it gives you some prognostic rating. So ABC subtype lymphomas typically have a less favorable prognosis as compared to germinal center B cell lymphomas. The problem here is that the primary CNS lymphomas are almost exclusively ABC subtype lymphomas. So actually the gold standard would be to do some gene expression analysis, for instance, RNA sequencing. So in the routine diagnostic setting, where we have limited tissues and mostly formalin fixed and paraffin embedded tissues, we do kind of a surrogate. What we do is a series of immune stainings for 3 different markers, for CD10, BCL6 and LAMP1. And the combination of positive or negative findings gives us the result whether this tumor or this diffuse large B-cell lymphoma falls in the non-GCB or GCB subtype. So this is the Hans algorithm. Then in addition, we're looking at selected markers. So we're looking at gene fusions, just to exclude some double hit lymphomas, some high-grade double hit lymphomas, which would typically have the MYC fusion and either BCL2 or BCL6 fusion. So in our case, all of them were negative. So we come up with a final diagnosis of a primary CNS diffuse large B-cell lymphoma of the non-GCB subtype.
How much time do you need to get to a diagnosis?
So at least we try to have the first feedback within 4 days. By then we should know that it's a malignant B-cell lymphoma of diffuse large B-cell morphology. And then we have another 10 days where we do a more detailed molecular makeup of this case, where we have the results of the fluorescence in situ hybridization and we know the gene fusion status. So this will be in a second step and will take a little longer.
Mm-hmm. So this may be a question to Uwe as well. Is there a treatment difference in these subtypes?
The answer was no. There is no treatment difference in these subtypes. Maybe in the foreseeable future, when we have advanced targeted therapies, this may well be the case, but for the time being, no. Okay.
So after 4 days, we know that it's diffuse large B-cell lymphoma. We can proceed with the patient and think about treatment. So that's what we did. Again, the diagnosis in our patient. And then I would like to return to you, all people that are joining this webinar, with poll 4. Barbara, could you please do this poll again?
So, can this patient be cured? This patient can be cured, but the chances are small, 20%. This patient has a good chance on curation, larger 80%, and this patient cannot be cured. We're at 60% who voted right now. We will wait for some more seconds. 54% said that this patient can be cured, but the chances are smaller, 20%. 40% said that this patient has a good chance on curation, larger 80%, and only 7% said this patient cannot be cured.
Okay, well, curation, that's something magical for everyone who's treating neuro-oncological patients, I guess. Uwe, can you cure this patient?
I think the vast majority of the participants in this poll are completely right. Yeah, we definitely have, at least in the younger patient population, a fraction that may be cured, and it's probably looked at the general population, including the elderly patients, definitely less than 20%. So we had last year in neurology our 20 years follow-up of the series 65 patients treated with the Bond protocol, and we saw actually for patients up to 60 years a 10-year overall survival fraction of 53%, which is a lot. It applies to patients being 60 years and younger, but we have seen in these patient populations late relapses after 11 years, 13 years, and up to 21 years. So it's kind of a definition what you think is cure. If you, from an oncological point of view, say 5 years progressive free survival, this is cure, then definitely larger. A bigger proportion of patients are cured because we can put them into a good remission for several years, but there is a chance of very late relapses. So I guess it's decent to say these are 20% or even a smaller fraction which can be cured by modern therapy, but unfortunately the vast majority of patients are either primary refractory or show relapses within a few years time span.
So, do you need further staging in this patient?
The question is to me. I mean, you have done PET-CT, you have asked your ophthalmologist, you have done, of course, which is a staging, you look for immunosuppression. We haven't looked at this point in our discussion. You have to check HIV and hepatitis, and if this is staging, you need staging. Usually whole body CT scan, PET-CT, and the ophthalmological investigation, including slit lamp investigation, is enough staging. There's a matter of debate if we need a bone marrow biopsy. Probably not is the answer.
Okay, so would you do CSF and ophthalmology if it was not done before the biopsy?
Oh, definitely the ophthalmologist. It's about 10 to 15% of patients that harbor an ocular lymphoma, either at the beginning of the diagnosis or first or even prior to the occurrence of the PCNSL, or they will develop it later. So it's also a matter, an integral part of the follow-up investigations, the ophthalmological investigation. Yes, we definitely have to do this if it hasn't been done by now, and if the patient turns out now by the diagnosis of Dr. Wöhrer that he has a B-cell lymphoma of the brain.
Okay, so the first line treatment. Well, let's first ask the audience. What do you give, or what is given in your center? Barbara, could you do this poll?
Yes. So what's the first line treatment of your choice? Yes, so we have the chemotherapy metrics are 46%. 30% we have the chemotherapy RMBVP. Then we have only high dose methotrexate for 17%. Another chemotherapy is said 6%, and 11% said no idea.
All right, Uwe, how come we have so many regimens? And well, what do you think? What's the best regimen of all of these?
I mean, the answer is that all the regimens are justified, and that there is no, with the exception of matrix, we will talk in a minute about, none of the regimens that has shown clear superiority over the other. There is a consensus that first, high-dose methotrexate is backbone of every successful therapy. There is no debate on this. If you want to cure a patient, high-dose intravenous methotrexate for several cycles has to be part of the regimen. And there is a very good meta-analysis from this year in March, published by a Chinese group, dealing with all the additional regimens that are protocols that are added to high-dose methotrexate as a backbone. And it seems that both matrix, NBVP, but also VP, MVP are superior to the other regimens. So it is, I think, correct to say we need high-dose methotrexate-based chemotherapy, and some additional substances are need to add it to make the polychemotherapy more effective. But that's basically what the consensus is by now. So all the answer to your question, how can there be many different answers? Because the different answers are correct, but one would definitely add some substances to high-dose methotrexate alone, and I would not go for the 17% that say high-dose methotrexate monotherapy is appropriate.
And could I just echo this point there, and just to say in terms of the matrix, the International Extranodal Lymphoma Group carried out a sequence over many years of sort of exemplary clinical trials where they started with high-dose methotrexate, they then added drugs sequentially. So the second trial was adding rituximab and cytarabine and then adding thiatipa. So and in each one, the previous treatment had been the standard arm. So it was a very good model of the construction of a regime from a very logical basis.
I completely agree. They started off with a randomized phase 2 trial putting ARSC, cytarabine, to high-dose methotrexate, and then in the IALSG 32 trial with the outpoint measure response, they added, as Dr. Cowan put it, rituximab to cytarabine and methotrexate, and then thiatipa. The reason why I am reluctant to say that matrix is a kind of a standard, in contrast to the IALSG group, who thinks it is a standard, is matrix as an upfront therapy for 5 cycles with 4 different substances is a very aggressive induction regimen. And within the original trial, the IALSG 32 trial published in Lancet Hematology, only 64% of the young and fit patients who went into this trial and received matrix as an induction regimen moved on to consolidation. So they lost 36% of patients who could not be consolidated because they were in poor condition, they were poor mobilizers for other reasons. And that's the reason. Matrix by itself is a very aggressive and efficient regimen. And if you make it as a patient, you have a high likelihood of a response, 49% complete response. But the group itself de-escalates now the aggressiveness of this regimen because, as I put it, only 2/3 of the patients made it then to move on for consolidation, which in my view is the most important part of chemotherapy regimens. And we will go to this in a minute, consolidation.
And just one further point, I mean, Uwe, I share your views. Absolutely, this is an aggressive regime, and you mentioned a significant percentage don't get through it. And what I suppose the audience do need to remember is that this is a disease of the elderly, and many patients aren't fit enough to even embark upon matrix in the first place. So when you talk about the whole population of patients, a very small or relatively small percentage will actually embark upon matrix and complete it.
What kind of side effects do we need to consider in these regimens? What do we see?
Hematological ones. These are hematotoxicity. Yeah, this of course. All the substances have a high likelihood of showing profound hematological side effects.
We have a question from the audience. Would you also start a treatment without histopathological confirmation? For example, when you have MRI with a strong indication for lymphoma and the lesion disappears under corticosteroids?
This is a very interesting question, which puts us back to the beginning of this lesson. What is the differential diagnosis? And the differential diagnosis in this disease, in a clinical but more on an MRI point of view, are inflammatory mass occupying lesions like sarcoidosis, granulomas, like tuberculomas, like cases of vasculitis. And so a space-occupying lesion, which is intensively contrast enhancing and completely disappears under steroids, may well be a CNS lymphoma, but it may be a whole bunch of other differential diagnoses. So I would never ever give such an aggressive regimen that is necessary to treat appropriately PPNSL without having a clear-cut pathological diagnosis.
That's a clear answer. Thank you. Do you also treat CSF, like intrathecal chemotherapy?
Do you ask me?
Sorry, yes.
Yeah, I think we are the champions in intrathecal therapy, because part of our regimen is the intraventricular therapy placed or injected via an Ommaya reservoir. And there is, I know, in the Netherlands, a very practical attitude towards this intrathecal or intraventricular therapy in case you find lymphoma cells in the CSF, as for example, bilumbar puncture. The Bonn protocol, which is not definitely has some disadvantages, but part of it is the intraventricular quasi-continuous application of methotrexate, prednisolone, and RRC, because we thought that this tumor is adjacent to the ventricles and from a neuropathological point of view, frequently affects the meninges, and tumor cells reside at the meninges even if you don't find them in the CSF. So we do it, but we are a small minority of people who do it routinely on a theoretical basis. And in the Netherlands, I know you do it when you find the CSF contaminated by lymphoma cells.
Yeah.
We also did it in Vienna. There was a treatment with Ommaya reservoir, but then we stopped some years ago because we had a relatively high rate of infections. And I think that's also in some literature reports that the rate of infection with Ommaya reservoirs and this intrathecal therapy is elevated. That's why we stopped it some years.
I completely agree. It's not a simple procedure, and people may have an infection when leaving the operating theater, and people more frequently have this infections while being under treatment. Georg, you are absolutely right. And I think one of the reasons why we in our center had so many infections, 20% of patients with Ommaya reservoir infections, because these are severely immunocompromised patients having seen dexamethasone for weeks in some instances. That's the reason why in our center we don't treat patients at the beginning now with an intraventricular therapy. We do 3 cycles of systemic therapy, and in responding patients, we do this as kind of consolidation together, of course, with the systemic chemotherapy, which is the backbone, of course. But we have published these results recently in 2020, and we have now postponing the implantation of the Ommaya reservoir to a state of the patient where he or she is no longer on steroids, has left the bed and is mobile from 90% to 5%. So, but you are absolutely right, Georg. Ommaya reservoir infection is a problem and is probably prevents people from favoring this kind of therapy.
But that's maybe a good point to make it a little bit later and so reduce the risk. And who does the punctures in your department? A new surgeon as of the Ommaya, or do you do the punctures? Or?
The reservoir, of course, is implanted by the neurosurgeons, but the treatment, the repeated injections are done by the neurologists. I mean, there's a group of physicians who are very well trained in treating Ommaya reservoirs. As you know, in Vienna, these are the pediatric hemato-oncologists. They are great in avoiding any complications because it's an integral part of so many chemotherapy regimens the pediatricians apply that they are very used and very accustomed to it.
Okay, and well, to continue to the radiotherapy, Richard, do you think there's a role for radiotherapy in first-line treatment?
Thank you. It refers back to the point I made earlier that there's a significant, unfortunately, percentage of patients who are quite frail when they first present and quite elderly. And I think we would all agree that if you don't use quite an intensive chemotherapy regime, then the chances of getting a long-term remission are very small. And so there is a place for giving whole brain radiotherapy for patients who are not deemed suitable for chemotherapy for whatever reason. And I think the most important issue about radiotherapy, there's no question that across the sphere of lymphoma, radiotherapy is a highly potent agent. We use it in all other areas of lymphoma. And there are arguments in favour of why it will be effective here. One of the most striking things of CNS lymphoma compared with all other forms of lymphoma is that it stays localised. The number of patients who actually develop distant lymphoma from primary CNS lymphoma is extremely rare. So it is local control of the disease within the CNS that we are trying to achieve. The greatest obstacle we have with radiotherapy is that because of its more diffuse nature, we tend to give whole brain radiotherapy rather than focused radiotherapy, and that in contrast with other brain tumours. And as the age of the patient increases, the neurocognitive impact is greater, and so there is a great need and there's greater research interest in looking at more sophisticated ways of delivering radiotherapy to reduce the amount of dose to the whole brain and to be able to focus radiotherapy more towards the tumour, thereby reducing the chance of late morbidity but maintaining the chance of local control.
Okay, thanks. So before we continue, our case underwent matrix without severe toxicity, and the MRI after completion of the treatment regimen, we have it here. So I just want to go back to Teresa. Can you please show us what the treatment did for this patient?
Okay, so for us to assess response, we rely on contrast enhanced MRI. And here we see on the image on the left, the MRI at diagnosis, and then the MRI after treatment. And we see that there is a resolution of the contrast enhancing part of the lesion. We cannot see abnormal contrast enhancement in this case. So we would have a response. Now we need to have information regarding corticosteroids and the eye examination in order to know if this is a complete response or an unconfirmed complete response. Because sometimes we have slight areas of contrast enhancement that are small but may disappear over time or are related to the procedure of the biopsy. But in this particular case, we see no contrast enhancement.
Okay, thank you. Just to see whether the audience is still on board, we do our final poll. Barbara, could you please do this one? This is poll 7.
Okay, so how to consolidate in this patient. Whole brain radiotherapy, stem cell transplantation, intensified conventional chemotherapy, non-wait and scan. Now the results. 15% for whole brain radiotherapy, 38% for stem cell transplantation, 25% for intensified conventional chemotherapy, and 23% for non-wait and scan.
Okay. Uwe, what would you do?
I would like to agree with the majority of the people participating in the poll. Consolidation therapy, I think it's fair to say that high-dose chemotherapy with autologous stem cell transplantation with the Freiburg protocol is decent in this 58-year-old patient. So this 58-year-old patient should be able to tolerate high-dose myeloablative chemotherapy and stem cell transplantation in order to avoid radiotherapy. There are good data. I think it's a decent protocol, and it's a good protocol. In my department, we offer, of course, intensified conventional chemotherapy in addition to intraventricular therapy, as I have put a few minutes ago. But this definitely is no standard. So it's decent to recommend to this patient in order he has no if he has no contraindications, high-dose chemotherapy with the Freiburg protocol and stem cell transplantation. Yes.
Okay, thank you.
I would not to start a discussion with Richard, if he likes. I would not, in the first place, put this patient on whole brain radiotherapy as kind of a consolidation, even if the IELSG 32 study for the secondary endpoint with regard to consolidation therapy could actually show no difference between whole brain radiotherapy and high-dose chemotherapy, but the authors vote for high-dose chemotherapy in order to avoid radiation-induced neurotoxicity. I think Richard would agree.
Yes, thanks, Uwe. I think the paper that we're all referring to, the ILSG 32 paper, has been sort of practice changing. And just to confirm that in that study, once patients had got into a good remission with the matrix, they were then randomized to either a autologous stem cell transplant or radiotherapy. And actually the outcome in terms of survival and control was no different between the two arms. But as we've just touched on, the neurocognitive long-term impact was worse in those groups with who'd had radiotherapy. Now, the issue about when you've got a good remission, as in this patient, and let's say they're not going to have intensive further chemotherapy, should we give radiotherapy now, or should we wait and have it in reserve for the time that they relapse? That study has never been done and nobody knows. If we assume that bone marrow transplant has had an impact, has reduced the chance of recurrence, then from that study we must assume that in this setting so has a whole brain radiotherapy, because the outcomes, as I say, were similar. I think the striking thing about that ILSG 32 study was that we gave full dose radiotherapy in patients who are in a complete remission. And I think there's a very strong argument to say that those patients in a complete remission probably do not need that intensity of radiotherapy, and that we could get away with lower doses. And I think the other thing to say, and this just goes back to the general population, moving away from clinical trials to our general practice, as we've alluded to before, quite a lot of patients aren't fit enough to have intensive chemotherapy in the first place. quite a significant number embark upon chemotherapy and have to stop early due to toxicity, or they have a partial remission. In other words, there is still disease there. And in all those cases, we know that there's a strong argument for whole brain radiotherapy.
Thank
Here's
you.
an audience question from the audience to Richard. Is there any place for stereotactic radiosurgery in the treatment?
Yeah, that's a very good question, and it all comes down to whether our lesion is unifocal or multifocal. And the radiotherapy that we've been delivering in the past has treated the whole brain to a certain dose, and then we have boosted to the site of original disease. In patients who've got unifocal disease, there is a strong argument to use stereotactic. Either, well, I wouldn't use I would use small volumes just for people to be happy. We're talking about the same thing. Stereotactic is obviously treating a very low volume, but it's also treating a very high dose per fraction. I see no benefit in this condition for giving that very high dose per fraction, but I would focus on the very small volume of treatment.
I think this is definitely worthwhile considering in an individual case. We have to be aware of data on this. And I think we should not leave our audience with the possibility here to use at first line or part of a first line regimen focal radiotherapy. I think what would be much more interesting, we have these patients that respond to therapy, they show a recurrence, they respond again, they show a recurrence, and they have always a unifocal disease in one spot. And we actually, so I think it doesn't make any theoretical, it's theoretically not justified. We did focal radiotherapy in these patients, so in third line and fourth line treatment, where we also had no chemotherapeutic reserve. And if they have unifocal disease, the tumor is recurrent always at the same spot, and I think then it's worthwhile considering focal radiotherapy in order to treat the tumor and to avoid neurotoxicity. But I think this is just a personal opinion and by no ways standard of therapy and no recommendation.
We left the second line treatment out of this webinar, mostly for the sake of time, to be honest. But thank you for your personal opinion so far on this. How do we do the follow-up? How often do you do MRIs in these patients? Uwe?
The first 2 years, every 3 months. Then after completion of 2 years of follow-up, every half a year, and after 5 years, annually. This is what the IPCG has recommended many years ago. And please include into this monitoring for follow-up always ophthalmological investigation and a neurological examination, of course, as well, not just MRI of the brain.
Yeah, and you told us that you do see late relapses, so I assume that you do this lifelong?
No, I mean, a single case of a patient with a relapse after 21 years is, in my view, no justification to do this lifelong. I mean, we have to consider then when patients suffer a relapse, they get symptomatic within very few weeks, and then they come to our attendance. And no, I would not advocate doing this lifelong, but what the IPCG suggested is, I think, still valid and is for 10 years.
Okay, okay, thank you. Our case, 5 years later, he was still clinically and radiologically stable. So I think we did well for him. I think this was a very interesting webinar, and there are a few learning points that I just wanted to wrap up with the audience. First and foremost, in case of a suspected lymphoma, do not give steroids. I think we've pointed out that one again and again and again, but that's the way we learn, right? Don't take too much time awaiting diagnostic tests. Georg told us that he tries to do a biopsy within 24 to 48 hours. While we had a discussion on CSF, yes or no, ophthalmology, yes or no, we should not forget to to hurry up in these diagnostic tests. And again, curation is possible in this disease, but it's a very toxic chemotherapy regimen, whichever you choose. That were my learning points, at least for today, and I hope the audience has had many more. Barbara, could you please do the closure for today? Barbara, are you still there? We prepared the last number of this show, just to make like our learning point on the steroids clear again, and that's the vanishing lymphoma. Barbara, are you there?
Yeah, sorry. Yeah, we had this one case with the vanishing lymphoma where we had the MRI. Maybe Teresa, do you want to explain again the?
Okay, so we have on the left coronal T2 with a very heterogeneous lesion with edema, and we see on the middle image the T1 weighted image post-contrast showing an homogeneous enhancement in the posterior putamen in the lesion. And then on the third image, we see a reduction of this contrast enhancement on a patient that is on steroids. So this is the point that we have focused before during this seminar, that we need to take this into account when we are aiming for a biopsy, for instance, that this may happen.
I think you did a biopsy in this case, Barbara.
Yes, we did, and we had a diagnostic tissue.
Heidi,
Almost
diagnosis?
almost diagnostic tissue. So if you remember this very compact infiltration of these densely packed proliferations of B cells, then in this case, almost all B cells were gone. So there was only one focus, and in the H&E staining, it looks not very remarkable, but in the immunohistochemistry, you find this focus where we still have these large B cells, together with many apoptotic figures. This is very suggestive of a residual disease lymphoma. It's also it also fits that the MIP1 proliferation index, so the MIP in the middle, every cell that is stained here in brown is a cell that is actively cycling. So the MIP here in this case is very, very low, which is actually not very suggestive of a neoplastic lesion. But given the fact that this patient has received steroids before the biopsy, this might well be explained by the steroids. So it could be a treatment effect. So it would still be in line with a lymphoma, or compatible with a lymphoma. And so this was how we put our diagnosis. So it was very suggestive of a B-cell lymphoma, but we could not really give a 100% diagnosis, but we also had a differential diagnosis of other inflammatory diseases.
So again, the learning point of the steroid, and I think this illustrates really well why we try to avoid the steroids if we can. Thank you. Thank you all for your participation. Thank you very much to the experts. It was an honor working with you. This very rare but important disease, and hear your opinions, the evidences, but also the controversies. And I hope the audience has learned as much of it as I did. Thank you very much.